Move to the next speaker, Dr. Mehak RAHEJA and Dr. Neeraj Kumar Yadav. You be ready as soon as she's done.
Okay. Good evening, everyone. I'm here to talk about navigating the intricacies of superior orbital lesions. So orbital lesions can be infectious, inflammatory, traumatic, neoplastic or vascular, and the most common superior orbital lesions include dermoid cyst, like lacrimal gland tumor, hemangiomas, cellulitis, or non-specific orbital inflammations. So this study highlights the various superior orbitotomy approaches and a range of diagnoses in different age groups. This was a prospective interventional case series including 5 patients with similar presentation, 4 out of which underwent orbitotomy with varied approaches and 1 underwent intralesional therapy. So talking about the case series and the results, the case 1 was a female 52-year-old who presented with right eye proptosis, ptosis, hypoglobus. CT scan was suggestive of irregular hyperdense mass. CT scan showed an irregular hyperdense mass and a differential of orbital tumor or lacrimal gland pathology was made, and subbrow incision was given, and histopathology was suggestive of adenoid cystic carcinoma of lacrimal gland. The patient was planned for surgical excision, but then was lost to follow-up. In case 2, this was a 71-year-old male presented with left eye ptosis, upper eyelid fullness, restriction of ocular motility and proptosis. MRI showed heterogeneously enhancing lesions and differential of lymphoma or metastasis was made. A transconjunctival incision with lateral cantholysis was done. Histopathology was suggestive of small cell lung carcinoma, and PET scan confirmed metastasis, and the patient was referred to oncology department. In case 3, it was a 62-year-old female who presented with left eye proptosis and upper eyelid swelling. MRI showed an ill-defined mass with leading to a differential of orbital inflammation or infection. Lid crease incision was given and orbital mass debulking was done, and histopathology was suggestive of necrotizing granulomatous inflammation, suggestive of tuberculosis, and the patient was referred to chest medicine. In case 4, it was a 6-year-old child who presented with left eye inferior dystropia and upper lid fullness. In this, the MRI was suggestive of heterogeneously enhancing lesions along with bony defects. A differential of histiocytosis or osteomyelitis was made, and a subbrow incision was undertaken. Histopathology revealed coffee bean appearance, and it was suggestive of Langerhans cell histiocytosis. And the patient was referred to the pediatric department, where he was started on oral steroids and injection vinblastine. Case 5 was a 12-year-old child who presented with left eye proptosis, inferior dystropia, restriction of movements. MRI was suggestive of hyperintense mass with septations, leading to a diagnosis of lymphovenous malformation, and an ultrasound-guided aspiration and intralesional bleomycin was given, and the child improved clinically on follow-up. So, dermoid cysts are more commonly observed in pediatric patients, whereas malignant tumors are more typically seen in adults. All of these have a common similar presentation. Therefore, it is important to remain vigilant for less common entities such as metastasis and orbital TB. For superior orbital lesions, lid crease incision, subbrow incision, or transforaminal incision can be given as performed in this case series. And the evaluation requires a multimodality approach. To conclude, a similar presentation can lead to a diagnostic dilemma, and there could delay appropriate treatment. Superior orbital lesions present similarly but have a diverse etiology. MRI and CT scans are essential but may not always provide definitive answers. Therefore, biopsy is mandatory. So this case series highlights a critical role of tailored surgical planning based on the lesion's characteristics and suspected diagnosis, and a multidisciplinary approach is required for every case. These are the references. Thank you.
Thank you, doctor. That is a good series.